All right, guys, welcome back to another series of Best Provider Spotlight. I'm here with my colleague, Dr. LeBrun, with the Fondren Orthopedic Group. Welcome.
Hey, Dr. Wong. Thanks for having me. I appreciate the invitation to be here.
Yeah, for sure. So for those of you who don't know, Dr. LeBrun is a orthopedic surgeon with Fondren Orthopedic Group who specializes in hip and knee replacement surgeries. So today I'm going to ask a couple questions so the viewers can get to know you. We're going to talk all about the hips today. So the first question I have is, what made you decide to be an orthopedic surgeon?
Yeah, the answer actually pertains to hips. So it's a good first question to ask. So I knew that I wanted to be a surgeon from a fairly young age. I sort of had this inkling in like even middle school, high school, like I wanted to help people and I wanted to use my hands. And there are a lot of different ways you can do that. But the way that came to be for me was being a surgeon. And so between college and med school, I had the opportunity to travel abroad for a year to study surgery in low income, low resource settings around the world. So I was in South America, Southeast Asia. I was in sub-Saharan Africa for an entire year looking at this. And the experience that sort of got me hooked onto orthopedics and I never really looked back from happened in Peru. So I was helping some orthopedic surgeons from the States actually come down. They came down several times a year to the Amazon rainforest in central Peru. And essentially they came down for like 2 weeks at a time, did a bunch of orthopedic surgery, helped a lot of people, and then they would fly back home. And they had doctors on the ground in the interim to sort of help follow those patients. And I was essentially serving as a Spanish translator for them. And the first surgery I saw them do was a hip replacement on a guy he was a father, he was an active man, like in his 40s or 50s, and had a motorcycle accident, broke his hip, had no access to surgical care to fix it. And he basically became bedbound, unable to bear weight on his hip at all for years. He sort of lost the ability to provide for his family and really lost a lot of function. So they did a hip replacement on this guy. And I remember seeing him the next morning up and walking again for the first time in years. And from that point onward, I was like, this is cool. So in med school, I entertained a lot of different things. I tried to keep an open mind, but at the end of the day, orthopedics was what I wanted to do with my life, specifically hip replacement and knee replacement, because I thought that the ability to do good with those procedures was so profound. And so that's what got me into orthopedics. And I am here now as a hip and knee replacement surgeon.
That's awesome. Yeah, you definitely can see the transformation of patient that comes see us before surgery, like hip and knee replacements. And then after the replacement, they're like a completely different person, right? And it only gets better with the right rehab. And so we definitely appreciate, what you guys do for our patients and just patients overall. So that's great.
Yeah.
So what makes you different from other orthopedic surgeons who do, hip replacements?
Yeah. So there's sort of two ways to answer that question. So I'll give you the first sort of cheesy way, and then I'll give you a more objective way. So I really value like patient care and the human interaction. I like sitting down and spending time with patients. My clinic may run a little bit late as a result because I like to give every patient the same amount of time that I would give a family member. And so one of the things that I value or that I like to practice is just being kind to people, listening to their story, understanding what they're going through, shaking their hand, looking them in the eye and understanding what's going on and not just treating their x-ray, right? I think it's very easy, especially as an orthopedic surgeon, to treat an x-ray. But what I like to do is really like focus on the x-ray, understand what's going on, but treat the patient and what they're going through. So that's the cheesy answer. I guess the more objective answer is I came from an institution in New York. I trained there where we did the most hip and knee replacements in the country. We had over 15,000 hip and knee replacements a year there. And then from there, I was able to train additionally in Europe. So I was given the opportunity to learn how the Europeans do hip and knee replacement, especially like complex primary and revision surgery. So I got to train in Germany, Switzerland, the UK, and Italy, and understand a little bit more, gain an international perspective on hip and knee replacement. And then I came back home to Texas and now I'm here. So I come with the perspective of a really high volume, advanced center in New York, as well as the perspective of how Europeans have been dealing with these same problems using slightly different approaches, different techniques, and now practice that here in Houston.
That's awesome. Would you say the techniques that you learned in New York compared to Europe is wildly different, or there's a lot of similarities and just like very tactical differences?
They're mostly similar. I would say 80 to 90% of what we do is similar. Right? And there is a lot of overlap, right? We have Americans who go to Europe to train, and we have Europeans who come to the States to train. And some of the people I learned from in Europe had previously trained in the institution I trained at in New York, right? So most of it's similar. I think there are some unique differences in sort of specific treatments for specific conditions. For example, in Germany, I really went to the European epicenter for infection care, so infected hip and knee replacements, and understanding how they treat those in one surgery rather than two, which is how we've mostly done it here in the States for a really long time. Understanding that, doing bikini approach, anterior approach hip replacements in Switzerland at the place where they sort of originated that idea, which is a slight modification of how most surgeons do anterior approach hip replacements here. So the subtle things, most of the surgeries, most of the techniques are the same. The patient care is excellent across the board, but just learning some subtle differences about how they do things there, I think I was able to collect and bring back home.
Yeah, for sure. And, you bring up a good point about, spending the time with the patient, because we send several patients your way, and, when they come back, they're always like, yeah, Dr. LeBrun actually spent the whole session with me. And that's surprising to them because, their prior experience with other surgeons is they get in, X-ray, and then they're out the door in like 10 minutes and they're still like wondering, well, I had a bunch of questions, but he only saw me for a few minutes. So now I guess I have to make an appointment to see whoever, right? So we really appreciate that about you, just, giving patients the time to ask their questions and clear up anything that might be, scary and fearful, right? Because I think that managing expectation is a big thing for a lot of patients, especially if it's their first hip replacement, right?
Right. And I think that's so true. And what I've learned a lot from the past is helping manage other surgeons' patients and understanding that, after surgery, if they have questions about swelling, if they have questions about how long they're going to have pain, if they have questions about what level of function they're going to have at 2 weeks, 4 weeks, 6 weeks, what have you, I sort of like to take all that information and provide all of that on the front end. And admittedly, some patients are going to ask those questions anyway, but I think it's helpful to manage their expectations early. And I know we're talking about hip replacement, not knee replacement today, but for knees, for example, I tell most patients, like, you're not going to like me very much for the first 3 to 4 weeks because the recovery is really hard. And I have patients come back at week 3 and week 4 saying, you're right. I sort of like you, but I don't like you that much right now. And it's better to have warned them than for it to sort of come as a surprise. But I do like spending time with patients. But to be honest with you, all those patients that you've referred to me, they may like me, but they love y'all. So.
It's a two-way street, right? You take care of them on the front end, we take care on the back end, and it just becomes a great relationship. So thank you for what you do for everybody.
Likewise.
Yeah. So can you tell me about who is your ideal patient for hip replacement?
Yeah, so my ideal patient for hip replacement is someone who is very motivated, who understands their own health and wants to be better, who wants to have more function and a higher quality of life than what they have. And they feel like their function and quality of life is impaired by their hip, right? And the other thing too is I really will not talk about surgery until a patient has tried several other techniques first, right? So that would include things like anti-inflammatories, Tylenol, activity modification, stopping doing the things that make their hip hurt every time, right? Stopping running, go to cycling or something else. Physical therapy is an important one. I want them to have tried that, right? And other things like injections, right? So if they've tried everything and they come to me and say, look, I just want better function. I want my hip to stop hurting. That's the ideal patient. If a patient comes in having not tried any of those things, I won't really broach the topic of hip replacement other than as sort of like this is something we might talk about down the line, right? So ideal patient is someone who is motivated, wants better function, quality of life, less pain, and has tried a bunch of other techniques first.
For sure.
Yeah.
So I know when it comes to total hip replacement, you have the anterior approach and the posterior approach. Can you talk a little bit about like what each of them are and kind of what the recovery process looked like, or what the differences are, pros and cons of each?
Absolutely. It's a great question. There's, this is a conversation that gets brought up a lot when I talk about hip replacement with patients. So currently in 2025, there are two primary ways to do a hip replacement. There are others out there, but these are the two that 99% of surgeons do: anterior approach and posterior approach. What that really means is from the front and from the back, right? Posterior approach, posterior means like back, but it's really more from the side, whereas anterior approach is more from the front, okay? There are pros and cons to each of these approaches. I will tell you that about 90 to 95% of the hip replacements I do are anterior approach hip replacements. If I wanted a hip replacement for myself or for a family member, I would recommend or want an anterior approach if I were a good candidate for it, okay? Not everyone's a good candidate for it, and that's why about 5 to 10% of my hip replacements are posterior approach hip replacements. And posterior approach is a perfectly good way to do a hip replacement. And I train doing more posterior than anterior hips in training, and now in practice, I'm mostly anterior approach. So the principal benefit of an anterior approach hip replacement is stability. So the risk of dislocation, and this is not just my numbers, this is like national numbers, the risk of dislocation after an anterior approach is about 1 in 1,000, whereas it's about 1 in 100 after a posterior approach. Okay, so that's a factor of 10 difference. That's a big difference, right?
Yeah.
So that is the biggest, I think, advantage. The other advantage in my hands for anterior approach hip replacement is that when I do an anterior approach, I have x-ray in the room and I'm checking my work as I go. So there are no surprises. Like the x-ray that I get in surgery is the exact same x-ray that I see in when the patient gets it in recovery, right? And it's because when you do an anterior approach, the patient is just lying on their back, and it's very easy to get an x-ray and to assess what you're doing implant-wise intraoperatively. So the disadvantages of anterior approach are some patients have numbness over their thigh after surgery, and sometimes that is persistent. Rarely does that bother them long-term, but in order to do that surgery, there's a nerve that basically crosses right over where our incision normally is, and some patients have numbness in their outer thigh after surgery. The other issue, and this goes into patient selection, is that some patients can have wound issues, meaning that the wound does not heal that well. And so what I'll do every time I look at a patient who's a candidate for hip replacement, I'll look at the skin around where I'm going to make the incision. And if the skin does not look good, let's say there's possible infection brewing around that area, or like some cellulitis or something, I will absolutely not do an anterior approach hip replacement. If the skin is very, very thin, I will not. And if they have an abdomen or belly that's sort of overhanging where I would do the incision, I will not do that, and I'll do posterior instead. Okay. So contrast to posterior approach, I think posterior approach has a couple distinct advantages. One is rarely, if ever, do patients have wound complications after surgery. Rarely. The skin heals up really nicely. Two, the exposure, the ability to actually do the surgery is really easy. Once you do it, the surgery I think is a little bit quicker if you do it from the back than from the front. From the front takes a little bit more time. The downside of it is that you do have to take the gluteus maximus muscle and basically split it in half and then put it back together. You're not necessarily cutting the muscle, but you are splitting a very large muscle and putting it back together. And there are two muscles that you do have to cut, and then you repair back together. Okay, that's sort of the downside of posterior approach. The principal downside, of course, being that the risk of dislocation is a little bit higher than an anterior approach. Overall, both approaches are very good. My patients who have either are equally happy. The data would suggest that in the first 6 weeks after surgery, patients with anterior approach tend to recover faster than patients with posterior approach. And at 1 year or even 6 months after surgery, they're all doing the same, right? So it's a short-term benefit for anterior approach. The long-term is about the same. The one caveat to that is the dislocation risk is lower in anterior approach.
That's a great answer. That's a common question we get asked all the time. And for the most part, most of our patients we see in the clinic who come to us after hip replacement are posterior approach. And the very few that we get that are anterior approach, like you said, they recover so much faster as far as like that first 6 weeks and stuff. So definitely in line with kind of what you're discussing for sure.
Yeah. I think there's a lot of talk about like muscle sparing approaches in hip replacement. And I think people equate the anterior approach to a muscle sparing approach. I think to some degree that is true. We don't take any muscles and split them in half like we do in the posterior approach. We take the TFL, which is a muscle on the outer part of your thigh, and sort of move it aside, and then it just falls back into place when we're done. So I think there is something to be said for that. Like we're not cutting as much muscle when we do it from the front.
Yep.
That said, when we do it from the back, we put those muscles back where we found them anyway. So I don't think that's what makes the difference. In other words,
Gotcha.
I think at the end of the day, both of them tend to do pretty well, but the recovery is just a little bit quicker with an anterior approach.
Yeah. So you mentioned that like 6 weeks, usually first 6 weeks, easier recovery for anterior typically. But for the full gambit, would you say it takes about a year to recover from total hip replacement, whether it's anterior or posterior?
It's a good question. So I tell patients that they'll be about 95% better by 2 to 3 months. Okay. So the full recovery after hip replacement takes longer than that. I would say somewhere in the 4 to 6 month range. I definitely think if you define recovery as sort of like no more pain and back to the activities you like to do, I think it takes somewhere around 3 to 6 months to get there. If you define it as like, I'm so much better than I was before, it just takes like 2 months to get there, right? Or less. But even then, you know, if you're looking more forward to like a year or more, of course, patients are going to continue to get stronger, right? They're going to get back to the activities they like to do. They're going to be able to walk more. They're going to be able to play whatever sports like they do, or like playing with the grandkids or what have you. They'll be able to do that better. So I do think there's continued recovery, right? It's not like you're bad at 2 months, but in 2 months and 1 day you're excellent. It's sort of like a gradual recovery. But yeah, I would say about 95% of the way there is when you're at 2 months.
Awesome. Cool. What's something that most people don't know about hip replacement that they should know before getting a total hip replacement?
Yeah. So I have a lot of patients that come in and they try to push it off as long as they possibly can. And I completely understand the tendency to want to push off a major surgery, undoubtedly. Understand that. But our data looking at patients who have hip arthritis and following them over time, most patients who get a hip replacement tend to say they wish they'd done it sooner, right? And I think that's just because they sort of wait until the hip is really gone, like bone on bone arthritis, lots of bone spurs, very, very stiff, very functionally limited, using a walker, using a cane. And an intervention a few years earlier probably would have led to a few years of better quality of life. And I don't think people really appreciate that until they're already past having the surgery.
Yep.
Yeah.
And what is like, how long does a total hip replacement last for if they take care of it and do all the rehab and, you know, lifestyle changes afterwards?
Yeah, so that's another great question. So I tell patients that at 10 years, about 90% of patients still have their same hip replacement. And at 20 years, it's about 80%. So at 30 years, it's in the 60 to 70% range. So 30 years out from their surgery, the vast majority of patients still have their hip replacement. And then I clarify that by saying that data is based on implants we put in 30 years ago, right? Because we don't know, like we've made modifications and improvements to the hip replacements that we have now. We don't know what a hip replacement that was only developed in 2024, how long that's going to last until 2054, right? But we do think that we've taken what we have done in the past and made it a little bit better. So long story short is about 80% at 20 years, 60 to 70% at 30 years.
Okay.
Yeah.
That's a great answer. What's your thoughts on getting physiotherapy before or after hip replacement surgery? And is there like more cases of physiotherapy needed after an anterior approach versus, you know, posterior approach, in your opinion?
Yeah, so that is a great question. One of the things that I look for when I'm looking for a good surgical candidate is like, have they tried everything else, right? And everything else certainly includes physical therapy. And so I will ask them, have they tried that, right? And then if the answer is yes, then that sort of checks that box. If the answer is no, then it's a conversation, because if they have severe bone-on-bone arthritis, they failed multiple injections, they failed anti-inflammatories and Tylenol and everything else, then I'm not going to necessarily send them to PT because I think that patient's ready for a hip replacement, right? But if they have mild to moderate degenerative disease and they also have issues, let's say like with their back or with their knee, and I think that physical therapy would be of some functional benefit to them before surgery, and I don't necessarily think they're there yet to have surgery, then absolutely I would refer them to physical therapy. And I think that a patient coming in with better strength, better mobility, more baseline function, is a patient that's going to have better strength and better mobility and more function after surgery, right? So the way they get that is through physical therapy. So I do think it is important to do preoperatively. Postoperatively, I think physical therapy is important for a subset of patients, right? So I don't necessarily prescribe PT for 100% of the patients I operate on and I do total hips for, but I do for patients who I think would benefit from it. And that can be a number of different patients. So for example, I've got patients who have Parkinson's, who are having a hip replacement. A patient with a mobility disorder like that, I want them to go to physical therapy, right? I want them to be able to mobilize better in a safe environment. Patients who have other issues going on, and many do. For example, if they also have back issues, if they've got knee issues, if they've got contralateral hip issues, and I think that their mobility is going to be slowed by the other issues they have going on, then I will refer them to physical therapy. Patients who have had revision hip replacement, meaning it's like a redo hip replacement surgery, I think those patients recover much slower. And I think it's helpful to go to physical therapy early for mobility and later on for strength and range of motion. Strength and range of motion are not things that I want to be working on immediately after hip replacement because I really want the soft tissues to heal. I think that's an important part of it. But later on down the line, like 6 weeks after, that's when I would initiate physical therapy for those patients. So it is important. It's just not something I necessarily prescribe for all patients.
Yeah, that totally makes sense. Every patient is different, so you have to pretty much gauge where they're at and decide what's the next best course of action. So that totally makes sense for sure.
Yeah.
What does the process look like to work with you?
Yeah, so I'll normally see patients in the office. I see patients in Kingwood and I see patients downtown at Texas Orthopedic Hospital. So I'll see patients in the office. We will get x-rays of your hip, sometimes of your back, and have a long conversation about what's bringing you in, what bothers you, what you've tried thus far, what you haven't tried. I'll do an exam and then review the x-rays with you. I'll print them out. We'll draw on them. I'll show you what a normal hip looks like, and then I'll compare it to what your hip looks like. And then we'll have a conversation about what to do next, right? And so I want to sort of put everything together so that the patient understands my thought process. I don't just want to walk in and say, you need a new hip. I want to walk in and basically have a patient feel like they are on the same page as I am as to why they need a hip replacement if they do, what the alternatives are, what the risks and benefits are. So after that happens, if I think they need something like physical therapy, I'll refer them to y'all. If I think a patient needs some anti-inflammatories or an injection, then I'll do that. And for that subset of patients who have tried everything and they're good surgical candidates, we'll talk about surgery and what that process entails.
Yeah, awesome. If there is one thing you want to be known for, what would it be, Dr. LeBrun?
Good patient care. Like it goes back to what I was saying earlier. Like I want to be known as the doctor that people can come to and be able to tell their story and get someone to actually listen to them, examine them, figure out what is going on, and then decide on a treatment plan together with them and their family. That's what I want to be known for. I mean, I would love to be known as like the slickest surgeon around, but that's not what we can see, right? Patients don't necessarily see how slick you are in the OR. They see your demeanor, your bedside manner, right? And so that's what I would like to be known for.
That's awesome. Yeah. And how can people get in touch with you?
Yeah, so a couple different ways. They can either call our office. They'll get my assistant, Riley, who's always available. And our phone number is 346-615-9391. And then they can also email our office at LeBrunoffice@Fondren.com. Both of those ways will get Riley or myself, and they'll be able to schedule an appointment that way.
Awesome. Thanks for your time, Dr. Ron. Really appreciate it.
It's my pleasure. Thank you so much, Dr. Wong, for having me. I appreciate it.
Yeah, for sure.